This Coloplast digital textbook chapter will cover surgical indications for men with Peyronie's disease. Hi, I'm Larry Levine, Professor of Urology at Rush University Medical Center in Chicago. Today we're going to talk about surgical indications for treatment of Peyronie's disease. The indications for surgery for Peyronie's include the man who has at least 1 year from onset of disease and has 6 months of stable disease where there is no structural change. There should be a painless deformity, and he should be unable to or compromised in his ability to engage in sexual activity. This may be due to deformity, but may also be due to inadequate rigidity. He would have failed conservative therapy, having extensive plaque calcification, and clearly this is the man who might want the most rapid and reliable result. The preoperative consent is critical, as many of these men are devastated by this disorder, and therefore it's important to set expectations regarding the outcome from surgery, as many of these men would like to be able to have an erection much like they had as a younger man, and therefore we should counsel them that there may be persistent or recurrent curvature. I tell the patients that my goal is to make them functionally straight, which would mean something less than 20 degrees in any direction. There can be loss of length. They're more likely to be shorter with a plication versus a grafting procedure. There can be diminished rigidity. In all the published studies, there is some evidence of reduced rigidity, not always fully erectile dysfunction, but this may be especially at risk in the man who undergoes a grafting procedure. This appears to be most dependent upon the preoperative erectile quality. And lastly, what has not been looked at regularly in the literature is decreased sexual sensation. This seems to be common early after surgery, but it does appear to improve with time as the nerves recover. Several surgical algorithms have been published, and I've pulled them together here in one group. And it really boils down to two factors, the quality of their rigidity and then the severity of their curvature or other deformities. So when the rigidity is adequate with or without oral pharmacotherapy, the first approach would be tunica albuginea plication when there's a simple curvature of less than 60 to 70 degrees. No hourglass deformity or hinge effect, and when the penis is of adequate length such that a loss of 20% or more of length would not result in substantial shortening of the penis. For men who have more severe curvature, such as greater than 60 degrees, or who have a destabilizing hourglass deformity or hinge effect, then incision or partial excision and grafting would be indicated. When rigidity is not adequate for sexual activity, with or without a pharmacotherapy, a penile prosthesis is indicated. This can be done by just placing a prosthesis alone, and it is important to have cylinders that have adequate axial rigidity. For that reason, I do not recommend the LGX type of cylinders. If you do not get adequate straightening by placing the prosthesis alone, which happens in about 4 to 5% of cases, then we move on to modeling. Steve Wilson introduced the modeling concept back in 1994. It was a major advancement to simplify this operation to straighten the penis. If modeling is not satisfactory, then an incision would be made in the tunica to release the tethering nature of the tunica. And if the defect created by that incision is greater than 2 centimeters in any dimension, then a graft should be applied.